Yeah. Hello. Yeah. Okay. I think we'll get started with announcements. Good morning, everyone. Welcome to Geriatric's Grand Rounds. Our speaker today is Dr. Noelle Marie Javier. And a couple of announcements first before we get started. The next journal club is the 13th of February. That'll be on Zoom. The presenters are Casey Johnson and Hillary Lum. Other announcements: following today's grand rounds, you'll receive an email with the link to the recording of today's presentation. Please submit questions in the chat or Q&A boxes anytime during the presentation, and then you'll receive an online evaluation or in person if you're here today for the presentation. A quick introduction. Dr. Javier is a friend and mentor of mine from Mount Sinai School of Medicine. She's an associate professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai in New York. Apart from her clinical duties, she's involved in research and has had opportunities to publish and conduct presentations at a national, regional, and international level, such as at AGS, AHPM, the International Congress in Palliative Care. Her areas of scholarly interest include wound care, pain management, palliative care in the nursing home, palliative rehab, pediatric palliative care, and LGBTQI and holistic medical care. Please welcome Dr. Javier.
Thanks, you guys hear me? Thanks, everyone, for this invitation. It's really such an honor, and what an opportune time as we're facing a lot of stress, and that's an understatement in terms of the politics that we're in, climate that we're in. I don't want to get overly political, but I can't also gloss over the fact that some of the slides will pertain to some oppressive practices that are already being implemented as I am speaking. So feel free to call me Noelle Marie. My pronouns are she, her. And as Devin said, I don't want to add any more to that introduction. I don't have anything to disclose. Feel free to stop me at any time if you have any questions. I do want to say that this is such a packed topic of presentation that, you know, I'll try to accommodate questions in between, but if we can get through the entirety of the session, I think that would be great. And then we'll devote the last 10 minutes for Q&A. So over the next 50 minutes or so, I really want to hit on three important points. One is just a touch on the generalities as far as the epidemiologic landscape and healthcare disparities affecting our older LGBTQI+ adults. But because I also practice hospice and palliative medicine, I also can't exclude that part. And I've done work around this area as well in terms of the subspecialty. So I'm going to touch on a little bit of that. And then I wanted to provide some foundational concepts and constructs, but also really summarize it into one framework that you guys can take with you when you interface with somebody in this population, whether it's in the outpatient clinical setting or inpatient clinical setting. And this is really in reference to the biopsychosocial, cultural, religious, and spiritual framework that was lifted out of Dr. Engel's biopsychosocial approach to pain management. And then finally, I wanted to operationalize this talk by giving very concrete, inclusive, and affirming clinical care and communication strategies as we interface and take care of our patients. So one of my favorite authors, activist, and such a good friend of Malcolm X, Martin Luther King, is James Baldwin, and also a good friend of Maya Angelou, is also one of my favorite writers. And I think this really resonated with me, and I really wanted to include this in all of my talks because I think it's such a powerful quote. Not everything that is faced can be changed, but nothing can be changed until it is faced. So, you know, if there's anything that I'll leave you with today, hopefully it's this inspiring quote by James Baldwin. So let's look at the facts in terms of the epidemiologic landscape affecting this population. So the Gallup poll is a think tank that collects sexual orientation and gender identity information for Americans. And they usually conduct telephone surveys. This was started back in 2012, where at that time, about 3.4% of the population identified as LGBTQI+. LGBTQI+ is a shorthand for lesbian, gays, bisexual, queer or questioning, transgender and gender diverse, and intersex for the I. And then the plus includes all of the other diverse ranges of identities and sexual orientation that is not called out, but definitely still takes a place at the table. Otherwise, it would be such a very long acronym. So, so this data was being collected, which was really great because it provided representation, it provided visibility for the community. And as you guys know, if there's no visibility and representation, then the powers that be would not be able to allocate resources as far as research goes, as far as policymaking goes, as far as clinical care goes. So this is really important. I could not overstress this enough. But then, of course, in the period of 2018 and 19, as you can see here, there was a rollback here in terms of that collection because of the current presidency, who was president then. And, there was definitely not a lot of emphasis around collection of SOGI data. But then thankfully, it kicked up again. And in 2023, there were about 7.6% of Americans identifying as LGBTQI+. And this is about, definitely twice as much as how we started in 2012. So just looking at our older adults, now certainly we have the silence generation and then the baby boomers comprising our older adults. And we can see here that amongst the respondents, a lot of them are the younger generations identifying as LGBTQI+. And there's a lot of reasons for this. Obviously there's a lot more comfort, a lot more security, a lot more acceptance. And in our older adult population, there's definitely a lifetime of historical trauma that would not really allow them to express themselves in a fully authentic way. And so it's not, so these are all under, and even like this proportion is still underestimated. It is projected that in 2030, there will be about 7 million older LGBTQI plus adults who are 65 and above. I do want to point out to the 2017 data, both for Gallup poll and also from this independent think tank called Movement Advancement Project. They partnered with this older adult organization called SAGE, which stands for Services and Advocacy for GLBT Elders, which is kind of like the mothership for our older adults in this population in terms of access to resources, information, and so forth. And they conducted a study, and then they entitled the study Understanding Issues Facing LGBT Older Adults. And what they found in their study was that 50 and older, which we know is not considered geriatric strictly in a definition way, it comprises about 2.7 million, but then 65 and above, it's about 1.1 million. And about 1 in 5, or about 25%, or 1 in 4 to 1 in 5, actually are people of color. So those who are in the BIPOC cohort as well. So they also came out with some considerations in aging, just comparing it to the general population. And people always think about successful aging as a goal. However, I do try to not use successful aging as a term or as an adjective, just because I feel like it's a moving target, especially with our older LGBTQI plus adults. I would rather use the terms or the adjectives productive, resilient, because again, this population has undergone a lifetime of discrimination and trauma. There's a lot of reliance on paid and unpaid caregivers that are not necessarily biologically related. And there's definitely still a lot of gaps as far as inclusive care, for this population. I also try to veer away from the use of competency, because competency is not a finite skill that you will be able to attain even if you arm yourself or equip yourself with the tools to try to understand different cultures and different lived experiences of individuals. But just for the purpose of this paper, what they did identify was that for this successful aging in the general population, that it really has to do with three important points: economics, connections, and of course, health and well-being. In 2016, the National Institute on Minority Health and Health Disparities designated the LGBTQI+ community, also known as SGMs, or sexual and gender minorities, as a health disparity population, really requiring its own emphasis as far as research goes, as far as policymaking goes. The first case study that I wanted to call out is a dear friend of mine whom I lost to cancer. His name is Jay Palio, and he was a man born transgender. And he and I really bonded a lot in terms of the different barriers to care that a lot of the members of the population experienced, because he had gone through different phases in his life to get to a point where he was able to live authentically as himself. But one poignant point that he shared with me was that back in 2008, so Jay, just so you guys know, he's such a great advocate. He was a paramedic. He even campaigned for Hillary Clinton back in 2016. And he volunteered at the World Trade Center when it was attacked and bombed. And so Jay in 2008 was diagnosed with breast cancer. So he went to his surgeon and then hoping to get the results of the biopsy, right? So the surgeon shared with him that he did have breast cancer, but guess what the surgeon did? Instead of putting everything in place to try to do more workup and even plan, the next step, which would be to excise the tumor and whatnot, he referred him to a psychiatrist, right? So he was devastated. He was demoralized. He ended up finding a provider that really took the onus to correct the wrong in this situation, and he was able to receive the care. And then later, about 8 years later, 2015, 2016, he was again diagnosed with metastatic lung cancer. At that point, it was really such an honor for me to serve as one of his palliative care doctors, to be able to take care of him at the end of his life. But certainly during the time that we had multiple conversations about some of the trauma that he has endured over the years, he really illuminated a lot of these barriers stemming from ongoing invisibility and explicit and implicit biases, structural barriers, gaps in regulations, gaps in policymaking, gaps in research. Then there's also this lack of inclusive and affirming medical care for this population. And we know for a fact that a lot of this stems from stigma, stems from prejudice that comes with the territory of being identified as LGBTQI+. Because then when we realize, when there's a lot of bad rap and sad news around this, it registers in our minds, and then we develop our own preconceived notions about the lived experiences of these individuals, and it does trickle down. It does affect how we conduct ourselves in providing care to this population. So I always like to mention or to include this cartoon of the map of the United States, depicting different restrictions as far as protective policies in place. Of course, this website is now no longer in existence now, but I always wanted to, because I thought that this was such a good illustration of different states having different priorities and where the LGBTQI+ community really stands. So you can see here, a lot of protective policies that are in place for various domains, whether it's education or healthcare, or access to public accommodations, employment, and et cetera. You can see that there are states that are much more progressive in comparison to other states that are not. And about, more than half, unfortunately, are not as inclusive and affirming and welcoming to the community. And so you can see that in red, some states in the Northeast, a few in the Midwest, Southwest here, and of course in the West Coast, California and Oregon and Washington, a lot of these progressive states have policies in place to protect individuals in the community from being discriminated against. And then the rest in gray, unfortunately, do not have these policies in place. So in 2022, there was this independent United Nations expert by the name of Victor Madrigal Borlos, who was assigned by United Nations to come here to the United States to look at the state of LGBTQI+ as a whole in terms of healthcare, employment protections, and whatnot. And what he found in his independent study was that even though the community has progressed, and there were significant strides as far as having all these protective policies in place, there's also a lot of assaults and attacks that were emerging at the time in 2022 and continuing to do so over the next few years, as we're seeing, right? So I think it's really important to keep this in mind, that even though the community has moved a couple steps forward, they're also moving a couple steps back because of this yo-yoing of the political climate that we are in. The American Civil Liberties Union has a website that's actually tracking legislation being introduced in the House, in the Senate, and this is just hot off the press. I just copied this about a week ago. There were close to 250 anti-LGBTQI+ bills. In 2024, though, I will say we ended at more than 500. So this is just the start for 2025. We're already like nearing half of the 500 that the 2024 bills are at. And obviously, there's definitely emphasis on protecting trans and gender diverse rights. So we're seeing this now, right? In terms of executive orders, yesterday, hot off the press, there was an executive order banning trans and gender diverse women from competing in sports. And we know that this is just the tip of the iceberg. There's a lot of a bigger catch here. And it's really, and pardon my reach, but it really is erasure and potentially even extermination of the LGBTQI+ community, so much so that people will just have to leave or, be invisible. And, the cohort that is being most targeted are the trans and gender diverse youth with access to gender affirming care. And then it also trickles down to different areas in government, like in the military, and as I said, in all of these policies that are in place. And we're already seeing this happen with the repeal of RV Wade, all of these different minority populations, from women to individuals who are able to bear children, to immigrants, to trans and gender diverse individuals, and really the LGBTQI+ population as a whole. So this is, I'm just riveted and really disheartened by all of these events that are happening right now. And I really hope that we as a country will be able to stand together and fight. And then I wanted to segue into the economics as well, because as you guys remember, in terms of the cornerstones for productive and resilient aging in this community, that unfortunately, a lot of the members, a third of them, live at or below 200% of the poverty level. And again, this is not rocket science. We know for a fact that there is discrimination going on in employment. They're being ostracized from their families, so they don't necessarily have, especially if they're younger, they're thrown out into the streets. They engage in commercial sex work or in dealing with illicit substances or street use of substances and so forth. And I think that these all tie into the economic hardships that this community face over time. What they also noted that people who are living at the poverty level or below that, it's the rule of 40s. 40% are octogenarians, 40% are people in the BIPOC community, 40%, more than 40% are bisexual, and also trans and gender diverse individuals. These are two populations that are cohorts that are not generally understood well by society, that is very cisgender and heteronormative, and so much so that, again, there's a lot of de-emphasis and invalidation of the sexual orientation for being bi and your gender identity for being trans. So as far as research gaps are concerned, so yesterday I just went to our good old friend PubMed and tried to do some research. And then I said, if I were to pull out articles, let's say looking at, so I just, I always am enthralled with cardiology because there's always such great work, and the breadth of work is, I cannot keep up with, the ACC guidelines in terms of care. So this is always like a good, specialty to kind of take a look at as far as research goes. So I looked at cardiology and geriatrics, and then I also did search terms for cardiology and LGBTQI+. Lo and behold, I was able to get, for cardiology and geriatrics, 10,512 hits. And then if I factored in cardiology and LGBTQI+, there were only 8, right? And then I went into geriatrics and LGBTQI+, because, we practice and provide care for our older adults. And what did we find? 50. So much better than cardiology and LGBTQI+. Better, we're better in that regard. And then if I wanted to get the intersection of the 3 areas in medicine, do you guys want to guess? Raise a show of hands. How many say 50 and above? 25 and above? 15? 10? Less than 5? You guys are all correct. So it's only 1 that I was able to find. So again, this is a testament that there is a lot more work to be done around this area. And people do not always necessarily think about LGBTQI+ as a specialized form of medicine, which again, in reality, I also cringe when I think about LGBTQI+ affirming care as a specialty, because but we have to start from somewhere, right? And it's such a very nuanced, very focused area of need that it definitely has become a niche of mine. But I look forward to the day that this will just be ingrained in day-to-day practice, and we don't necessarily have to say, oh, we have to call it out as special, because, oh, really? Oh, amazing. Congratulations. There you go. I rest my case. So just looking at the more granular stuff as far as disparities in geriatric, and I just want to be mindful of time. So there's definitely harassment that's being afforded to this population. There's outright refusal of care, fear of persecution and discrimination in long-term care settings, so much so that people don't necessarily disclose who they are. There's reliance of unpaid caregivers, which I also now know that we're trying to shy away from the use of informal caregivers, because there's nothing informal about caregiving. That a lot of the older adults in the community are actually twice as likely to live alone. They don't necessarily have biologic or adopted children. And so when they get older, if they outlive, let's say, their chosen families, then they might not have anyone to take care of them. And certainly there's ongoing gaps in knowledge and training. Moreover, again, the trans and gender diverse communities are openly made fun of because of how they look, how they present. We already talked about rollback in terms of inclusive questions around surveys. And the sad thing about these disparities is that this becomes a perpetual cycle, so much so that our older adults are fearful of accessing health and health maintenance and preventative screening. And so this leads to developing cancer, cardiovascular disease, and so forth. So this becomes like a domino effect, that if we're not very intentional about what we're doing, that this could actually happen. And this is not to be an exhaustive list. There's so much more that I did not include, but I just wanted you to be familiar with them. So I have been fortunate to be part of a couple of collaborative projects with all of these different pioneers in the LGBTQI+ medical world. so to speak, from various institutions. And so in the subspecialty of palliative medicine, we wanted to look at the experiences of the community with the hospice and palliative care providers. Because guess what? Hospice and palliative care is supposed to provide that compassionate, that overarching kumbaya moment for our patients who are seriously ill, or so we think, right? When we looked at and we were able to collect about close to 900 respondents, we found out that over 50% of them have actually experienced observing and thought about, not observing, but really had thought in and of themselves that if you belong to this community, that you are going to be oppressed. And again, this is not rocket science. How many of them actually observed? Only a few, but this is also underreported. There's many reasons for this. Perhaps people that we were able to include in the study are the ones that are really invested, but there are a lot more. And the way that discrimination exists in day-to-day society, whether it's microaggression, it could be as subtle as microaggression or other forms, other verbal or little attacks and here and there, and that little jabs that could impact the mental health of the individual. And what again is staggering here was that 64% were trans and gender diverse adults. So some anecdotal experiences. A lot of these pertain to our transgender diverse patients. They were being called it instead of he, she, or they pronouns. People were giggling, joking. Families, biological families were contacted to make medical decisions for these individuals when they were already estranged from from their families. And then for individuals who have had gender affirming surgeries, they become a point of ridicule and curiosity because they really have to take a look at what the anatomical description is of what the person has. So a lot of things that are very disrespectful and discriminatory towards our transgender diverse adults. And then in a parallel study, we wanted to look at the experiences of this time. We flipped it around, families, patients and families with regards to their experiences with healthcare providers. This was a lower sample size, about close to 300. It was an online survey. And I call this the rule of thirds as well, that a third of the respondents felt that the providers were insensitive. They did not really know how to take care, how to even talk to their patients who were LGBTQI+. They were being misgendered. And again, a lot of these folks are also people who do not only carry one minority identity, but multiple minority identities as well, being Black or being Hispanic and so forth. So the data here could not be even more glaring. That's why I highlighted them all in red, because all of these surveys that came out really looked at comparing the general population to trans and gender diverse folks with respect to rates of HIV, incarceration, unstable housing, substance use, and everything across the board was definitely much starkly, higher in the trans and gender diverse adults compared to the general population. But what is really staggering here and quite chilling was the fact that in terms of mental health and patients, individuals attempting to complete suicide, 41% compared to only less than 2% of the general population. The largest, and I didn't include this here, but the largest study for trans Americans was done in 2015. And the reason I didn't include this is because it's the same data. 40% showed that individuals have attempted suicide over their lifetime. Compared to, instead of the 1.6%, the general population, it was about, I want to say 4%, less than 5% of the general population. So a little bit higher than this data, but still, in that ballpark figure. So again, just to point out that this was again a different study in 2015. That was kind of like the peak of a lot of the studies for trans and gender diverse folks. We can see that in green, again, across the board, housing issues, physical health, and mental health issues were much more pronounced in trans rather than their cisgender cohorts. So the net effects is that there's further invisibility, there's ongoing physical and mental health issues. Individuals will not want to get preventative health access because of fear of discrimination or being outed. There's ongoing persistent victimization. But then I think the other important piece to consider here is if there is no visibility, if you're not collecting SOGI, then the issue becomes that the individuals are not known to the community and to society as a whole. And so therefore, you will not really be invested in allocating resources and really taking care, developing high quality practice guidelines in the care of this population. So there has been a call to action for many, many years. In fact, in 2011, the formerly known Institute of Medicine, now called the National Academy of Medicine, identified that there are gaps in research for the community. And as healthcare providers, whether you're a social worker, whether you're a chaplain, whether you're an NP, PA, physician, we all have an obligation to take care of our patients, even if we don't agree with their lifestyle choices and whatnot, because it's not really for us to judge who they are as individuals. Our task is to focus and be objective on the subject at hand, which is their physical health and their mental health. And you can respectfully agree to disagree, and that's okay. This is democracy after all, right? And I think that as healthcare providers, we took an oath to be unconditional in our approach and to have that universal approach, because after all, healthcare is in fact a universal right for any human being. A lot of the organizations have came out with a lot of position statements that have been laid out over the years, from geriatricians to chaplains, the physician associates, psychiatrists, and so forth. Any questions before I segue to part 2? That was a loadful, right? Okay, so let's try to be more positive now, because there's a lot of things to tackle. But I wanted to share with you a few guiding principles. So of note, I'll start right off the bat that older LGBTQI+ adults have their own unique lived experiences and different journeys, and it's not a monolith. Just because you're taking care of one adult who's trans doesn't mean that you know everything about the next trans person. So we just have to keep that in mind. So, I love our subspecialties because there's a lot of overlap and intersection, right? From being person and family-centered care or caregiver-centered care. We do a lot of goals of care, symptom management, team-based approach. We do a lot of transitions in care. And I think that what can really thread them all even much more tightly is using a multidimensional or holistic approach, using this biopsychosocial, cultural, and religious and spiritual care framework. Because if we're doing that, and this is not intrinsic to the community in and of itself, because we can definitely use this, we can definitely use this for like any patient as a whole. Just really looking at them as a person that comes with multiple dimensions can go a long way. It starts with cultural humility. I so appreciate you taking the time of your day to come to this talk, because you're already taking the first step. The fact that you're coming here means that you're culturally humble, right? Because you may not, maybe some of you are experts already and some are not. But it's always good to have a lifelong commitment to learning, always be self-critical and reflective of what our experiences are. And we want to be able to dismantle any type of power dynamic between our patients and clients and the provider as well. So this should be something that should be included in our fabric of existence. So sexual orientation, gender identity are two different constructs. Sexual orientation is your affective, relational, sexual, emotional connection to a person or persons. And gender identity is your internal sense of being. How do you identify as? Are you a man or woman? And what society and even beyond what society dictates. And then there's also this question called assigned sex at birth. And I think that it's really important to include this in our intake forms, because this will also give clarity and representation, visibility to individuals who are trans and gender diverse. And there is this other construct called gender expression, which is essentially the physical manifestation, whether it's through your behavior, your outward appearance and whatnot, of who you are as a person. Suffice it to say that even though they intersect in this beautifully crafted Venn diagram, it's not mutually exclusive, and it doesn't really, it's not always concordant, right? A person can express themselves in a feminine way, but they are really a heterosexual cisgender person, right? So it really depends on that individual and allowing them to be who they are. At our institution, at my institution, we've included these questions to be able to call out sexual orientation, gender identity, and assigned sex at birth. So this is an example. So if a person comes into your clinic and then they tick off the box, they can say, they identify as a man for gender identity. And if there's an option for a transgender man, then they would check that off as well. Assigned sex at birth would be female. And then so you obviously know that this person is a man of trans experience, and the pronouns are he, him, his. And so when you include the pronouns and when you go into your Epic and interface with your client or with your patient, if these questions were already, if the answers were already populated into the questionnaire beforehand, then you don't need to ask them. You can just look at their name and their pronouns, and then you introduce yourself. And you introduce yourself and say, hi, I'm so-and-so. These are my pronouns as well. I'm going to segue into the lived experiences piece because I've been talking about this. All of us have lived experiences, but especially if you're a minority, your lived experiences are so colorful. And if you have multiple minority identities, it becomes even more colorful. And some of the theories that govern lived experiences are the life course theory, where an individual exists in society, they're shaped by different milestones, and then they thrive and live in society. And then there's also the goal-oriented theory, whereby individuals, as they age over time, particularly the LGBTQI plus adults, go beyond their own lived experiences and want to make a difference in the world. And so a lot of the advocates end up, really aiming for this goal-oriented theory as part of their lived experiences, because then at that point, they want to be able to give back. They want to be able to pave the way for the younger generation to not experience brutally what they've experienced over their lifetime of journey that was filled with discrimination. I also wanted to point out the minority stress model because all of these constructs are interrelated. This was created by Ilan Mayer, who's a psychoepidemiologist back in 2003. And what this really shows, and I'd like to use my laser pointer here. So what this shows was that as a person, as a human being in society, we all have circumstances in our environment, and these circumstances lead to general stressors, whether it's housing, paying the bills, getting your education, taking care of your kids, and so forth, right? However, if you're also a human being that carries with you minority status identities, right? Sexual orientation, maybe it's your color, maybe it's your class, maybe it's your ability or lack thereof, then you have your own unique minority stressors as well. And your unique minority stressors are then cumulative or add up or additive to your general stressors in society. So what happens? You have your allostatic load, right? And your allostatic load will reach a certain threshold where you will not be able to cope positively or productively. So what ends up happening is that you end up with mental health issues. But I will challenge this paradigm to not only include mental health, but also physical health issues, because they are interrelated, right? If you're so under stress, your cortisol levels go up. And then you end up, if you have oncogenes and cancer cells and so forth, you elevate your blood pressure, you promote the mutation of these genes, and then you end up with physical ailments that can impact your life. However, the good side to this is, and this is where the resiliency comes in, because a lot of our older adults have gone through so much that they've developed ways to be able to adapt, to be able to thrive in society, and they've developed coping skills. And I think this is such an important thing to recognize, because it's not all doom and gloom. There's so many great things about the community that if we just really take the time to get to know them, you'll be able to be inspired and learn from how they meander in life, and be able to be successful in their own areas. So I talked about resiliency, which is the ability of an individual to come back up when they're knocked down. And then there's also this concept, this twin concept of robustness, which is the ability of the individual to resist any type of change, to resist any type of, again, this is very idealized. And if you look at maybe Maslow's hierarchy of needs, it's probably more the, the top, the creme de la creme, which is the self-actualization piece. That no matter what stressors you are thrown at, you can rest assured that you are unflappable at that point. And then there's also this construct called crisis competency. Again, competence, but this has been borne out in the literature. This this originated back in the 80s during the HIV/AIDS epidemic, when a lot of the community members banded together to be able to help each other, form connections, really challenge the government, Reagan's administration at the time, and really was trying to make sure that that individuals are able to thrive and to survive. And we saw the crisis competency not too long ago. Do you remember which epidemic that was? This was like a couple years ago. This was the Mpox, right? That was an example of crisis competency, because at that point, all healthcare organizations, all these different organizations for LGBTQI+, they were out there publicizing the need to get tested, the need to get access to vaccinations, and so forth. Now, I like this cartoon. I borrowed this from one of my good friends who's a nurse practitioner at Sinai. So just bear with me, because this is a busy slide, but I just wanted to maybe just point out, the first column here. So a person, if you have an older adult who's 70 years old, who was born in 1955, and in 2025 is now 20 years old. At 20 years old, this person actually experienced or bore witness to a lot of these milestones. The Stonewall riots, Harvey Milk was assassinated, Anita Bryant was the singer who was very Christian and anti-LGBTQI+. And then when this person turned 30, 10 years back in 2035, now your older adult is now an octogenarian by this point. At 30 years old, this person actually experienced the gay-related immunodeficiency disease, which is your HIV/AIDS, the White Night riots, which was related to Harvey Milk assassination, people which were just like protesting. And then when this person turned 90 years old, at 40 years, this person was exposed to the Defense of Marriage Act. So a lot of these important milestones. And what I wanted to show here is that this has a profound influence on the individual as they age over time. And this could be a source of minority stressors. Now, what about the psychosocial piece? I'm not going to go in depth, and I'm going to breeze through some of these slides so we can get to the third part. Because for our social workers in the room and on Zoom, I'm pretty sure this is within your wheelhouse of expertise. But I do want to point out this, the one that I highlighted, which is disenfranchised grief. Are you guys familiar with disenfranchised grief? So particularly with our older LGBTQI+ adults. So because they have chosen families which are not necessarily blood related, a lot of the times, because of the continuing stigma and oppression of the community, when let's say an older adult dies, so there are chosen families, the care team might not necessarily give much emphasis on the grief of the individuals, the chosen families, because they're not blood related. So there's almost like an invalidation in terms of how you're providing support, because they're not blood related, so I don't really need to provide this additional layer of support. And so their grief gets disenfranchised, and it's getting minimized as well. Now, what about for our chaplains in the room? You guys are probably familiar with this theory called gerotranscendence, that as we age, perhaps a lot of the folks become more spiritual and really veering away from materialism and really being more mindful of our existential purpose. What we found in the study by Monin was that these veterans, the older veterans, had lower levels of mental health issues in in relation to anxiety and depression compared to their younger cohorts as well. And I think, again, part of that is as you age over time, you develop a lot more confidence. You really don't care anymore how people are treating you. You've amassed a lot of experiences in terms of the oppressive experiences that you've gone through throughout the years. And so you've now developed some level of robustness and definitely resiliency in that regard, and so much so that it's no longer an issue. For our individuals who are Black, there's so much tie-in with the Black church, and so we see a lot of conflicts around sexual orientation and gender identity disclosure because of them being Black and because of their affiliation with the churches. But suffice it to say that we also have very progressive churches now that are very inclusive and welcoming as well. But I wanted to highlight that in our Black members, that the religiosity and the spirituality side is such a big factor in terms of how they disclose who they are and how they even practice and express themselves as the persons that they are. So I'm gonna go into intersectionality. Are you guys familiar with the term construct intersectionality? So this was actually created by Kimberly Crenshaw, who's an activist, a scholar, a lawyer. And she created this back in 1981. She was involved in this litigation for like a motor company that excluded Black women from accessing rights. And what she found was that if you're Black and you're a woman, it's a double whammy. You're gonna get dinged, you're gonna get discriminated against. And so this has morphed into not just your gender or your color, but also other elements such as your education, your sexuality, class, language, culture, ethnicity, all of these important elements that you see here. And they're all overlapping and interlocking at the same time. What's really good about this construct is that though your intersectional identities can shape you and can give you the strength to be able to cement yourself in the world, it can also expose you to a lot of oppression and discrimination and mistreatment, quite frankly. So I'm gonna put myself as the second case study because I embody a lot of these intersectional identities that I'm talking about. And I would be remiss and I would be hypocritical if I did not tell you a little bit about my story as well, because I think that more than anything in this day and age, we have to stay defiant and we have to be really unwavering in our advocacy. So as a woman who was born transgender and identify as a straight woman, I carry with me a lot of these other intersectional identities. Being an immigrant, I did not grow up here in the States. I came here in 2004 when I was accepted to residency, and then I became a naturalized American citizen in 2015. But being foreign trained, I obviously had to make my way to be able to practice medicine here in the States. But I also carry with me my Asian heritage, my Filipino culture, and being Catholic, which is could be an ironic thing being a woman of trans experience, right? And we're tolerated, but not necessarily accepted. And on the left-hand side, I want to say that these are some of the challenges that I've experienced over time, whether it's looking at myself in the mirror and having this discordance in terms of who I am, and the finances and things of that nature that that I had to go through. But I also take pride in the fact that thankfully I have a very supportive family, and I was able to get to the position where I am at because of allies, because of people who I'm considered the wind beneath my wings that really supported me throughout this process. And I'm really humbled and honored and thankful that I'm able to exist in the world now as the woman that I truly am. And I have a lot more to say about that too, but I'll save it for later. But this is just, again, just knowing that sometimes the person in front of you may not necessarily know. A lot of the times people don't know my story, my lived experiences until I tell them. And then when I tell them, they're like, oh, wow, things of that. So you don't know who's the person like seated next to you. That person might be going through some important aspects of their journey that, that impact them. So just to summarize all of these, I just wanted to say that We need to be able to connect the dots and include all of these fundamental principles in terms of where this fits in the bucket. And I think this is a good snapshot of that. And hopefully the foundational tools that I shared are going to be helpful. So part 3, last but not the least. So let's go through some concrete stuff in terms of how you can actually provide inclusive and affirming care. You start with making sure that you have visible symbols of acceptance. Rainbow flag, gender neutral bathrooms, mission statements. You want to be able to listen to the stories of your patients and your clients. And in palliative care, there's this one really great question. It's called the dignity question, because you want to be able to honor and uphold their dignity. What do I need to know about you as a person to give you the best care possible? Right? If you start with that, it will break the ice, because that's just at the human level. And it will really resonate a lot with your patients, instead of being too intrusive and say, so tell me a little bit about the surgery that you've had, So even starting with this can be really helpful. Just as a note, for trans and gender diverse folks, there's some elements in their transition that you might want to be just privy to, whether it's mental health consultation, drug therapy, surgeries. This is just an examples of the 5 elements. They don't need to be chronological, and they don't need to be ordinal in any way. WPATH is a good resource for standards of care for how to take care of trans and gender diverse individuals. And mind you, you don't need to be an expert to be able to do this work. Because we're in geriatrics, polypharmacy is a big thing, and because a lot of our patients are on HRT or antiretroviral therapies for prophylaxis and so forth, or even our ARVs for HIV, you just need to make sure that you know what drug interactions there are and how that may impact their affirming care. There's always this question at the end of life, like, when do you actually stop hormone replacement therapy, whether you're on testosterone or estrogen? What I can tell you is that there have been no studies around this. And there are really no set guidelines. I think that what I can give you as an expert opinion is collaborate with your patient and really come up with a shared goal. So some scenarios, if you were in the clinic, you introduce yourself, you use your pronouns, and I'm such a fan of scripting. So you can use the dignity question here, or you can even say part of providing holistic and affirming care are, and then you mention your that's a way to elicit information without being too close-ended. When you're doing a physical exam, it's important to really partner with your patients and ask permission. Don't just do, people, are so curious that they want to look at the genitalia if you've had surgery, when the person's presenting complaint is, I don't know, an elbow pain, right? So unless you're thinking sexually transmitted infection, then maybe that might be, but other than that, and also body parts. So terms, so you might want to say, how do you want me to call, anatomical breasts? Because people might not necessarily, for men who are trans, they don't like to call it breasts. They want to prefer to call it their chest, So things of that nature. So just being mindful, use open language and, destigmatizing language. If you misgender an individual, I think that you apologize, you correct your mistake, and then you move on. Don't dwell. Don't, take too much time apologizing, because that will just call out more attention. And also always ask sexual health as well, because I think people shy away from sexual. I mean, we tend to do this now even with our non-LGBTQI plus patients, but more so that it's important for us to talk about this for both populations, right? I just included a few tips here, some resources in terms of SAGE, the Safe Zone Project. I think that we need to lean into members of our team. This is a holistic approach. This is not just a one-person expert who can do everything. And we all have our own disciplines that we are experts in. So let's collaborate together. So for goals of care discussion, this is very helpful. I'm not going to go in depth, because I think that this is, again, part of our fabric, because we do a lot of goals of care as geriatricians as well. You guys are familiar with the tools Remap and Spikes. Again, these are very helpful tools that you can take with you no matter who the person or client in front of you is. Second to the last, I created this framework and communication based out of the Vital Talk, and then really looking at how you might want to elicit goals of care conversation, and I just coined it, Pride Talk. So P stands for preparation, making sure that you're familiar with your patients. Perception, asking questions like, what have the doctors told you about what's going on, let's say, with your blood clot and your hormone replacement. And then R stands for reflection in terms of goals based on, X, Y, and Z. What are our goals that we need to attain towards? Or redirect if they're at a point where the HRT, let's say, is causing significant issues around their health, then perhaps it might be time to renegotiate and reframe that. Ask about resiliency as part of the R. For I, invitation, is it okay if I examine you, and so forth. Inclusion, intersectionality is part of this. D is dismantling biases. And again, the dignity question I think is really important here. And then E, you want to always attend to emotions, because a lot of the times, as I said, people have gone through so much trauma, and it's important that we approach this with a trauma-informed lens. So in sum, remember that taking care of this population demands a nuanced approach. No one size fits all. We want to be culturally humble, but also responsive to the needs of the population. We want to be intentional in terms of how we shift our tone, our language, our practices. And for those of you who are researchers and those who are administrators and policymakers, I think it's important to do more research and protective policies. Some resources here. And I just want to end with a quotes from Audre Lorde, who's a famous poet and also an advocate. And what she said was, I do not want to be tolerated or misnamed. I want to be recognized. And if you can't change reality, then change your perceptions of it. So with that, I will end my talk. Thank you. Oh, you're welcome.
Thank you so much, Dr. Javier. I wonder if there are any questions in the audience or online. Yes. Yeah. So
we can get political. I am not.
I'm going to ask it in the most apolitical way I can. Knowing the direction that the current administration has moved very rapidly, do you have suggestions for those individuals who may be interested in conducting research in this area, how to do so in the current environment, and how are you approaching this in the current environment?
Yeah, so that's a really great question. I can tell you right off the bat that I don't have definitive answers, but I can definitely guesstimate. And before I even begin to that, and as I said, we can be political, and I don't shy away from using words like DEI or LGBTQI+, because they are what they are. We can't use euphemisms or proxies. I do understand where institutions come from as far as, because this all boils down to grants, federal funding. And let's not forget, people who are receiving this grant, these are people like who are making ends meet, they have families to feed and so forth. So this will have significant impact on them. So there's a couple of ways, and I think I can probably just own up to this from my own lens as a collaborative researcher as well. I think, and I'm in a privileged state because a lot of the work that I've done doesn't really require funding, or if they did, it's mostly from private funders. So I think that might be one way. Of course, going into the route of no funding as a primary researcher is not going to be practical. However, going into, seeking perhaps private funding that is not going to be under the mantle of federal grants might be another way to, albeit probably much more difficult, but doable. I think finding allies in terms of researchers who already have some kind of work and are defiant against any type of changes, no matter what, will be a way to do so as well. I think that I think for just day-to-day individuals, just petitioning your local governments, protesting as part of the board for GLAMA, which is the Health Professionals Association. I'm part of the group that filed a lawsuit against Trump because of the executive orders around trans-affirming care. So there are many. Yeah, that's probably not the answer, that because it's such a difficult place to be in. I also understand where some people are like, maybe we need to tread lightly so we can still keep the funding, but not use words that could potentially be a red flag. And you know what? There's nothing wrong with that either. If what it takes is to be able to tweak some of that language and still get some level of funding for your research, but at the same time staying true to form, to what your intentions are in terms of what you're doing the research, that is in a way for you a way of protesting that you're already actually doing. And I see that as not as a flaw, but it's meeting somewhere in the middle. That is probably the best way that I could explain. I will say that at Sinai, there's like a whole a lot of discussions, and there's still not like one universal way to approach it. There's going to be a lot of iterations and permutations of how we can conduct the studies true to form with DEI and LGBTQI+, and not sacrificing that, but at the same time also making it sustainable, because we have to be practical as well.
I have a quick question for you. One of the early slides you had looked at visibility for the LGBTQ+ population, and in older adults, in the baby boomer generation, visibility is already very low. And in the current political climate, I think there's probably a reluctance to engage maybe those aspects of their personhood with the healthcare system. And I'm wondering if there are any like unique considerations for the clinical providers about how to do that, about how to facilitate an openness or care that matches.
Right. So I think that, so there are many ways, right? Number one, in your intake records, if you have SOGI on there, but also including an option to not disclose, I think it's completely fine. Because again, if people are being targeted and they feel that the healthcare organization that they're going into may not be inclusive or affirming yet because they don't have that reputation, then it's probably safe for you to be lying low instead of like proclaiming yourself until you have a good way to really anchor that on that this is a supportive place. I think asking the dignity question is a good icebreaker. What for the individual, because then it's not very closed-ended, and you allow them to share their piece, including your pronouns when you introduce yourself. If you have like a rainbow pin, these are very subtle ways. Again, for me, it's a form of, I have like a little rainbow pin. It's a way of protest, and I'm not scared of that. If that's what it takes for people to come up to me and be much more open in terms of disclosing their status. It is going to be a challenge because particularly with the older generation, they've gone through this, right? And they're already saying this is our own version of oppression. This is their own version. Well, I wouldn't say, because some people would compare it, let's say, to the Holocaust and whatnot, but it's totally different. But this is their own version of that horrific like attacks on the LGBTQI+ community. So I think if you have guardrails in place with opt-out and some subtle things that you can do, and also not only that, but if you are also in a place where you can stay true to form and remain defiant, I'd like to believe that my institution, Mount Sinai Health System, will continue to be defiant no matter what, because this is our own community. These are all members of the community, and we should not be using euphemisms and be in the veil of silence or of hiding.
Mm-hmm. Okay, one more question, and then I think we'll have to wrap up. Yeah.
Thank you for your talk.
Welcome.
I've noticed that we've been having a lot more like no-shows for patients because they're scared to interact now with the medical system. Any like advice or tips? Because like now populations that really need to be seen and be cared for and are already like underserved because of fear having to like not interact with the healthcare system. Any advice on like how even in a like a welcoming system to engage with these patient populations?
Yeah. So I want to say, so that's a great question. I want to say that it starts from within. I think that we need to have a sit down with the powers that be. Like I always challenge the powers that be, even in national organizations that I hold some leadership roles and some membership roles, always challenge the powers that be. What is it? Let's talk about the elephant in the room, and let's talk about how we can continue to be inclusive and affirming for this community. Are we going to stay defiant? Are we going to stay resistant to some of this the politicking that is happening, and again stay true to form, to our commitment to providing universal high quality care for this population? And if you have the support of the C-suite and leadership, then we should not be afraid to continue to publicize this in our web pages, in our intake forms, in our advertisements, in our clinics or in hospital spaces where we still have visible indicators of inclusion. But I do think that this goes beyond us, particularly as an independent provider. We have to get the stance of the powers that be. And if the powers that be do not support, then that really begs the question of what am I doing, with this organization? So I think that we need to be a little bit more brazen, because we still live in a democratic country, and we want to be able to uphold the ideals of humane care. At the end of it all, regardless if that person is LGBTQI+ or not, Black or white or whatever, that is a person. And the care should be afforded to everyone regardless of your identity. So start with the C-suite, publicize, do visible indicators, continue to recruit and really affirm. It's all about PSA, public service announcements, right? And say that this is a welcoming community. Have, support groups in place. We should not be retreating. If for anything, we should be acting up and raising our voices. Thank you.
Thank you so much for that wonderful presentation.
I've turned into this passionate advocate. I should run for office.